Hey, Dr. Lokesh, from wherever you are.
Good evening. Good evening.
Yeah. Good evening, everyone. Thanks again for joining us. Thanks again, Dr. Baltazar and Dr. Mankat, for again attending our sessions regularly. We have around 7 cases today. The chat will be open for others to comment upon their opinions and comments for the cases, and we'll take up questions along as the chat is filled up. To start off with the first case, Dr. Rama, you can go ahead with the case.
Yeah, good evening, everyone. So this child is a 9-year-old who presented with focal seizures, right upper limb seizures. There were a couple of vomitings before that. The child is a healthy child going to school, and child had one episode of, and then MRI was done. MRV was also done because the child's mother was having history of sinus venous thrombosis. So there is a doctor in the family, so they wanted to rule out that. And incidentally, this child also had superior sagittal sinus thrombosis. And so after that, when we admitted the child was having minimal right upper limb weakness and mild ataxic gait. That's all. The child was otherwise fine, and no history of fever. There were a couple of vomitings prior to this seizure episode. Then, all the infective markers were negative. And we also repeated the scan to make sure that there was a sinus venous thrombosis, and the area was also a little doubtful, the diffusion restricted area also. That's why we had to repeat it. Then CSF couldn't be done because when we had tried, it was a dry tap, and later the parents didn't agree for it. So she was antithrombophilia workup was done. Only protein C was mildly low. By that time we have already started heparin, so that could be attributed to that. And other workup of ANA, those all things are negative. Even the mother's workup is all negative only. And we have started her on direct oral anticoagulant rivaroxaban, and 2 months later we had repeated the scans.
Okay. You probably see the scans first and then pick up the decision after.
Yeah, sure.
Yeah. So the first scan was done in June this year, and you have the diffusion and the ADC sequences. And on top in the left frontal region, the superior frontal and also the parietal lobes, you can appreciate that there is some area restricted diffusion in the cortical and subcortical regions, demonstrating low signal reversal on the ADC sequences, predominantly in the subcortical regions of the superior frontal lobe. Coming down below, the central areas do not demonstrate any abnormalities. Possible subtle abnormalities in the columnar thalamic nuclei are there, but it wasn't showing reversal on the ADC sequences. Again, the posterior temporal and occipital lobes had some degree of high signal changes on the diffusion weighted sequences, but did not correspond to low signal changes on the ADC sequences. The posterior fossa structures did not demonstrate any signal abnormalities on the diffusion of the ADC sequences. On the FLAIR images, again, there were subtle areas of subcortical cortical hyperintensities, again in the superior frontal lobe and along the anterior cingulate cortex over there. Coming posteriorly, again, there's slight hyperintensity over here in the left parietal lobe. And as you move down, the central areas do not demonstrate any edematous or focal lesions. Posterior fossa structures were normal. Brainstem and cerebellum did not demonstrate any signal abnormalities. On the SWS sequences, some of the superficial cortical veins demonstrated these areas of blooming, possible slow flow or thrombosis. The superior sagittal sinus here, diploid, demonstrates blooming over there. The vein of Trollard, that is the area of vein of Trollard, demonstrates prominent and shows blooming. A possible subdural over there, very thin, could be artifactual, but yeah, these were the changes on the SWS sequences. And T2 weighted, again, you have this cortical edematous changes in the superior frontal lobe. T1 non-contrast, you can see that there is some hyperintensity along the superior sagittal sinus, that is the anterior and mid sections, which corresponds to non-visualization on the time of flight MRV. So there is non-visualization of the anterior and mid segments of the superior sagittal sinus. A follow-up scan was done 3 months later, and the diffusion changes, there are no new diffusion changes. You can see that the sulci is slightly prominent, which had the abnormalities in the first scan, but no area restricted diffusion. The rest of the brain also did not demonstrate any focal signal abnormalities. On the flare, again, the sulcus is again prominent over there. Again, no edematous changes on the flare. Posterior fossa structures also did not demonstrate any signal abnormalities. On the SWI sequences, the sulcus demonstrated these areas of hemosiderin deposition, which on the filtered phase have similar signal to the vessels. So this is likely hemosiderin. There were also some anomalous veins in the medullary regions along the left centrum semioval from the periventricular region going up to the cortex. There were two anomalous veins over there, which was not seen on the prior study. A tiny focus of microhemorrhagic foci in the left anterior frontal lobe over there. MRV, there was a recanalization of the thrombosed supraparietal sinus. Post contrast, there was no enhancement. So after the initial scan, we thought of possible postictal changes related to the edema. Infection, which came out to be negative. Possibility of MOG-related encephalitis was also considered. And also possibility of torch paralysis was raised. I don't know if it fits clinically or not. Dr. Ame, did the child have weakness after the seizure? Focal weakness?
Yeah, simultaneously only, but it has improved quickly.
Okay. So yeah, these were the possibilities we thought of. And yeah, I'll open the case for the panelists to discuss.
Yeah, here my main doubt is if there are these developmental venous anomalies, why weren't they picked up in the first scan? And the second doubt is whether they are related to the sinus venous thrombosis, or can these be the effect of sinus venous thrombosis?
Waiting for Dr. Manka's opinion.
Yeah.
Just to note, the first and second scan were done at different centers. So yeah.
Yeah. First of all, sorry, Nihaal, I joined a bit late. Question is about the venous sinuses, and there is thrombosis, as you can see. There's also a delayed venous return on that side. And the signal changes are in the same area, isn't it?
Yeah.
Okay. So if you just go back one or two slides to see where it all starts. So if there is a primary venous phenomenon going on here, and that's explaining all these changes, then we need to know what is driving the venous thrombosis. I wouldn't go into MOG and all that with these venous changes. It's unusual to call it. And I think the risks for venous sinus thrombosis should be explained first here in this case, which could be sepsis itself, but other factors to be considered as well.
A child didn't have any setting for that. There were 2 episodes of vomitings prior to this, but the dehydration setting, those things are not there. So I attributed the vomiting to the venous thrombosis itself, because following vomiting, child had seizures.
I have a question to the management. I guess you will continue with the anticoagulation for perhaps another 3 months. And then you could repeat the MR to see what's happening to these particular veins.
Because the superior sagittal sinus was recanalized, I have actually stopped anticoagulation. That is one more doubt clinically, whether I should continue it, because this was not there in the first scan as well. So I was not very sure whether these are the causes. I mean, this is the cause for thrombosis.
You gave rivoxaban, is it? You do use rivoxaban for venous sinus thrombosis? It's the
yes, ma'am.
Okay.
Yeah, direct.
No?
Direct. Yeah, oral anticoagulant.
Okay. Mother is also on that. You don't need to monitor anything, no? If you give that.
No, we need not monitor. We need not.
Because
mother is currently not doing anything. I mean, not on any drug. Mother. This mother's history was. Mother had only once, and then that was like 3-4 years ago.
Okay.
Ramya,
Sir?
two things. It was not during a pregnancy that she had her procoagulant state, mother.
No, sir, I asked for that. She told she was using OCPs, but then there was no she used it for like very brief time, and then she
Okay.
had.
Okay. Are there any autosomal dominant forms of inherited thrombophilia syndromes that we need to evaluate in this sort of situation in your literature review?
Thrombophilia syndromes. Only this
Autosomal
factor,
dominant because,
factor 5 Leiden can still be there, sir, in that case.
okay.
But
Okay.
then that was for the mother, it was done, it was negative. For the child also, it was done, it was negative. But
Okay.
after seeing the second scan, I was not sure whether we have to just attribute this to thrombophilia thing only, because DVAs are seen. Is it justified to continue oral coagulant, sir, anticoagulant, or the child is doing good otherwise?
Yeah, generally we give it for 3 months and you establish recanalization and then we stop it because the
Yeah.
procoagulant workup is negative. I don't know, Professor Volta, sir, do they do differently there? Do they give it for longer period?
To my knowledge, the duration of anticoagulation in sinus venous thrombosis is somehow controversial. Some people say at least 3 months, many give 6 months. You may have a point if you have recanalization, but I think it's to some extent a matter of opinion.
Yeah, sure. Yeah, we try to establish that a recanalization is there, then and no procoagulant state which will predispose to long-term recoagulation, and then we stop it. That's what we generally tend to do.
Yeah, that's the same reason I stopped, sir. But then whether because of these I need to continue, and can these be effect of the thrombosis that was that has happened? Can it be because of the backflow and then? But then the second two, I mean the third and the fourth image is showing like DVA only. So that was one doubt I had. Whether the hemosiderin deposit is because of the thrombosis.
What DVA are we seeing here, Nihaal? Sorry.
Not the DVA, these are, I mean, these veins over here.
That's fine. No, they have become prominent transmedullaries because there is a problem with venous drainage of that side.
Okay.
So I don't have new DVAs coming up from nowhere.
Yeah, because the first scan didn't have them. It will be probably unusual to have.
Okay, then I can take them as hemosiderin deposits.
No, these are the medullary veins which have become prominent.
No, the first two.
Yeah, these are hemosiderin. Yeah, in the sulfur
if
spaces
that's
over
the
there.
case, it can explain the effect probably.
Yeah.
Okay. Thank you.
Okay. Next case. Okay.
So this child is a 35-day-old child who was second boy of consanguineously married couple. This child was referred in view of some subependymal cysts which were found on NSG. Otherwise, the referring pediatrician didn't have any other concerns. Only for that they have referred. So the first child died at 5 days of life. They are given typical history of birth asphyxia, but we don't have the further details. And this child also had excessive crying and was not gaining weight very well. The birth weight was 2.8 and then the current weight was some 3.2. And then, but on examination, the child had some sutural overlapping, spasticity of all 4 limbs. Lower limbs was greater than upper limbs. And then umbilical hernia was also present. So that's why I thought we will do an MRI because of these findings in the physical examination.
Small
head circumference was 35, not very small for a 1-month-old. Yeah.
Okay. Yeah. So the MR images on top, we have the T2 sequences, and you can appreciate that the white matter is edematous, diffusely on both sides. There are paraventricular cysts which can be better appreciated on the flare sequences. You can see over there along the lateral ventricles and also along the frontal horns. So bilateral subependymal and paraventricular cysts along the lateral ventricles, diffuse white matter changes in the cerebral hemispheres on both sides, demonstrating no signal changes or refractory changes on the play sequences. The cerebellum was relatively spared in terms of the signal abnormalities. No atrophy over there. Diffusion, no diffusion abnormalities. Sagittal sequence had motion artifacts, but you can appreciate that the brainstem and the vermis are reduced in volume, so they are hypoplastic. Nothing on the SWA sequences in terms of calcification or hemorrhage. So we're dealing with diffuse white matter abnormality with paraventricular cysts, hypoplastic brainstem, and vermis. That reminded me of a companion case which we discussed previously of a similar age group. This child had vanishing white matter disorder, but also had bilateral cataracts. This was a case from Dr. Vivek. Again, just to look into the phenotype, they can present with subependymal or paraventricular cystic changes with these diffuse white matter abnormalities. The other differentials for the paraventricular cysts are many, but here are the lists. Commonly in paroxysomal disorders, but this child does not have any malformations. A PDH can have the prenatal onset or antenatal onset PDH can have paraventricular cysts, and other examples as listed here. The white matter refractory changes can be seen in these disorders. Vanishing white matter is a common example. Interferonopathies can also present with similar changes, and the congenital infections such as CMV and rubella also needs to be ruled out. But this child did not have any calcification or migration abnormalities. Galactosemia was again can present with diffuse white matter abnormalities in neonates, but I think this child did not have any cataracts or organomegalies, so that's a likely differential on the imaging. Homocystinuria, that homocysteine levels were elevated. They present with diffuse white matter abnormalities, but they usually associated with some degree of cytotoxic brain injury, which can be represented on the diffusion and ADC sequences, and can have typical cerebrovascular abnormalities and the dislocation of the lens. These are differential to be thought of, and I'll open the case for further discussion.
Yeah, this child had. Yeah, sorry.
Yeah.
There is no spectroscopy available.
No spectroscopy.
We have asked for it, Dr. Bolthauser, but then the child was not. I mean, the child woke up in the middle, and the parents didn't want to give anesthesia. Yeah, we couldn't do. So, homocysteine was on the higher side, 25. Generally, for neonates, when I spoke to biochemistry department, they told 10 is the cutoff. So then we got folate and B12 levels done, which were normal. And then methionine is also normal in this child. From the biochemical point of view, it fits into that MTHFR mutation. I mean, that MTHFR deficiency can have this kind of homocysteine elevation alone with normal methionine levels. On the examination, white matter disease, leukoencephalopathies was also one possibility that I considered. So will this fit into MTHFR?
MTHFR is very commonly seen in the population, isn't that right? Or again, a lot of people when screened will have it. So I don't think we can be specific.
Yes, I think so. Yeah.
Okay.
I was told yesterday by a neurologist that if you scan half the children of Britain, they will have MTHFR mutation.
So the next step will be probably genetic analysis, or what is your plan?
Yeah, that's my plan.
But Nihaal, from an imaging perspective, there is no specificity at all to these findings, apart from the fact that this could just be delayed myelination in itself, right?
Yeah.
And second thing, considering the location of the cyst, can they still be this conotal cyst?
The conotals are maybe these ones, but not the other ones along the frontal horns and the body of the ventricles. They're usually along the frontal horns.
But towards the lateral side only. No? That's why I had that doubt.
Yeah, but they're more superolateral.
But these cysts are
not
specific at all. They can be also transient. I think they don't really help in the differential diagnosis. For me, they are rather confusing. I try to ignore them, at least in this location.
Okay.
Okay.
Sure, then
maybe
I'll
get-
ask. Yeah,
get back to
genetics.
us, yeah.
Yeah, definitely. Thank you.
All right.
We look
Thanks.
forward for your results.
Definitely. Yeah. Thank you.
Next case, Geeta.
Yes, sir. This child, male child, he presented to us at 4 years of age. Now he is 5.5 years. He presented with left-sided progressive dystonias with lower limb more than upper limb, and also examination-wise had tendoachilles contracture and also left-sided dystonic hemiplegia. And he was born to third-degree consanguineous couple with a significant family history. He had normal development till 4 years of age, and there were no perinatal issues. So the history is like in the first child, his sibling also had a similar history of progressive dystonia and speech abnormalities, which started at 5 years of age, and then it has progressed. And he, within 1 year, he succumbed. His investigations were like NBS and Siyanka, Piyanka were normal, and lactate was elevated. And his MRI brain, we don't have the images, sir. Bilateral dorsal striatal lesion and left putamen atrophy were there. For this child, so we had an MRA. And later on, we have sent the genetics also. Can I discuss the genetics after MRA, sir?
Yeah. So we saw the MR images, and you can see that there is bilateral striatal necrosis, predominantly involving the putamen and the lateral aspect of the globus pallidus. The rest of the brain, there are no significant abnormalities. There's mild thinning of the corpus callosum, but again, the main changes are in the putamen and the globus pallidi. Some areas restricted diffusion peripherally, and on the T1 and the play sequences, again, hyperintensity with some tiny areas of hypointensities. SWA, there was no calcification or mineralization. Spectroscopy, there was a lactate peak. So based on that imaging finding, this is a case again from Dr. Lokesh, which was discussed earlier. Again, similar imaging findings, similar presentation. This child, when we presented, we thought of these differentials. Mitochondrial was the first possibility, then organic acidurias. This child turned out to have complex 1 deficiency. So to the genetics of the index child, Geeta.
So for this child, we have first done the whole exome sequencing. For that, we have we came NDU FS1 was segregated, sir. It was double heterozygous. So we did a Sanger sequencing, and it showed that heterozygous, but in whole exome, it was variant of unknown significance. So we went ahead with the parental testing also. So both the parents are heterozygous for this mutation. And clinically also, it was only a partial match. So later on, to correlate the genotype and the phenotype also, we had to do a muscle biopsy. In this muscle biopsy was suggestive of complex 1 deficiency with activity less than 20%.
I'm not a mitochondrial expert, but this complex is very complex. And if you have a deficiency, you don't know anything where exactly this is. So I wonder really whether this muscle biopsy was very benefiting your situation. I don't want to be too provocative, but I think your genetic analysis, I have not studied in detail, but I mean, you have 2 variants in the same gene, and both parents are carriers.
Both parents are carriers, yes, sir.
Would fit to a recessive
So
inheritance.
both parents. Yeah. Yeah, so the both parents were carrying 1 heterozygous mutation each, isn't it, Geeta? Are you clear on that?
Yes, sir. Yes, sir.
It's not the same variant they carried.
Same, not the same. So father was carrying the exon 8, whereas a mother was carrying exon 6.
So you need to clarify that when you are presenting. People will not understand. We have to be clear. So it is a compound heterozygous mutation. Both the parents were carrying one of these mutations, and that's why they had these children. But unusual that in a consanguineous family, you have a compound heterozygous mutation, usually we expect a homozygous hit. So that is the only concern. And when we discuss with the geneticists, they requested for another confirmation in the form of respiratory enzyme analysis, which is when we did the genetic analysis, the mitochondrial complex analysis, which demonstrated there was a less than 20% activity of the complex 1. These things are generally correlating, Professor Bolta, sir. But I think beyond this, we are not able to do further analysis. This is where our limitations are.
Thanks.
Okay, thank you. If there are no further comments, we'll move on to our next case.
So this child is a 5-month-old male child, well thriving, no perinatal issues, normal development. So he had fever, dull activity, and vomiting for 2 days, and with these complaints he presented to us. So going back to the past, like 1 month ago, prior to the presentation, he has similar complaints. He had a history of vaccination followed by fever for 1 day, and there were left focal seizures on the day 1 and day 3, for which he was hospitalized. And during that time, he also had respiratory distress and mild encephalopathy. So outside neuroimaging was done. Later on, sir, can you?
You want me to show the images?
Yes, like images discussion.
Okay, I'll show the images and yeah. So this is the first MRI, diffusion and ADC sequences, and you can appreciate that there is a cytotoxic brain injury involving the right perisylvian region, temporal lobe, and also the occipital lobe. No other areas of abnormal restricted diffusion in the rest of the cerebral or cerebellar hemispheres. Angiography was done. No stenosis or thrombosis of the main vessels of especially the middle cerebral artery. There was some paucity of the cortical branches, but that can be attributed to the edematous changes demonstrated in the brain parenchyma. Flare again, there is edematous changes in the areas corresponding to the restricted diffusion. The circle pattern is not visualized clearly. Again, the additional findings on the SWS sequences, you can appreciate that there is diffuse extensive subarachnoid hemorrhages in the bilateral cerebral hemispheres, right more than the left, and also subdural hematomas along the falx, the posterior cerebral convexities, tentorium cerebelli, the posterior cerebellum. Better appreciate on the T1 weighted sequences, again subdural hematomas with the posterior predominance, primarily involving the posterior convexities on both sides, extending up to the falx cerebri. And on the SW images on the orbits, you can appreciate that there is focus of blooming of at least on the right orbit. The left, not very sure or certain of the changes, but there was definite areas of abnormality on the right orbit. And if you go higher up on the T2 flare sequences, there were some areas of subgaleal hematoma in the right hyparietal region. Yeah, Geeta, you want to
Yes.
go ahead with
that time he was being treated at the other hospital for the persistent dull activity, vomiting, and with that MRI they were treated in lines of CSVT, and after about 15 days child was discharged. Child was all right for next 10 days and later on presented with the similar complaints to us. So this time we had noticed that there are like regression of milestones, in a sense the partial neck holding, poor weight bearing was there. There were no signs of dehydration, though he had vomiting 4 to 5 episodes per day, and examination showed hepatomegaly, and these vomitings persisted and child activity became dull. Sir, can you go back to the previous slides of investigations?
Yeah.
So outside investigations which we have was like HB was 6.1 gram%, and we don't have PT-INR from outside. LFTs were normal and EEGs were normal. When he presented to us, the coagulation, both PT and APTT were prolonged, normal electrolytes, normal LFT, and hemoglobin was 10.8 and peripheral smear was normal, normocytic, normochronic anemia. So we have suspected a coagulation abnormality, and so we sent a coagulation profile, and it was negative, which included PT-INR, thrombin, plasma fibrinogen, and factor 13. We have done an optal evaluation also, where we found right eye retinal hemorrhages. These were the pre-retinal hemorrhages, posterior and anterior to the macula. And also because of anemia and liver enlargement, we did the HPLC, which was normal.
These are just for the radiologist, HPLC for thalassemia.
Yes, yes, sir.
Okay. Okay, after that.
Here in our hospital, because of the persistent vomitings, activity becoming dull, we have done a repeat CT. And because of the CT changes, we have taken them for the surgery. And after the CT and all, like when we have asked the history again and again, they have revealed that there was a history of slippage from the parent's hand was present, but we don't have clear timeline like when this has happened.
Okay. So this is the follow-up CT. I think was done a week later from the MRI, and you can appreciate that there is significant progression of the subdural or extradural hemorrhages in the right side, compressing on the brain parenchyma. Subdural again, collections have progressed along the anterior convexities. The cytotoxic injury or the infarcted area demonstrates now pleiotic changes. On the VRT images, I could not appreciate any areas of any fractures. Even the CT, the bone cuts also did not demonstrate any fractures of the skull. So based on that, at least I thought a possibility of abusive head injury to be raised based on some of the findings which are described over here, which was also seen in our case. If you're not thinking of abusive head injury, then the mimics to be considered, but the thrombophilia and blood workup was completely negative. There was no sign of infection. Vitamin K deficiency also was not present. I don't think the child had rickets. There was a history of trauma, but I think it was only a single episode, but the child had recurrent episodes of encephalopathy. Is that right, Geeta? 1 month prior to?
Yes. Within 1 month, there were 2 episodes.
Okay. Yeah. So yeah, these are the differentials, and again, papers from Dr. Mankad will be commenting on this case, and is an authority on the abusive head injury related topics. So I'll leave it out to Dr. Mankad for his comments.
Yeah, I agree with you, Nihaal. I mean, everything here fits with the abusive head trauma. The only problem now is being treated as CSVT. You probably have made the hemorrhage a bit worse, isn't it?
Yeah.
And the hemorrhagic transformation of the infarct that you see on the right side.
Yeah.
Why would anyone call it this venous sinus thrombosis is unclear still.
It was done at another center, and yeah, that was reported and proceeded initially for that.
Yeah. Do you have any T2 sagittal through the neck, for instance?
No, there was only one T1 sag, and this is the one we have.
It's hard to say anything in terms of ligamentous injuries there. Right?
Yeah.
Can I put the question, if you have the suspicion of abusive head trauma and retinal hemorrhage, would you not consider to take a skeletal X-ray survey to look for previous fractures or callus or rib fractures?
Totally, Eugen. I think the first suspicion has been raised at this meeting by the looks of it.
Geeta, anything?
Yes, we didn't do the skeletal survey, sir, because almost at the time of the discharge, they have revealed the history of this slippage from the hands. So initially, we were not suspecting that.
But
I think you are obliged to do a skeletal survey, Geeta. And then I want to know from your center's practice, what will happen in terms of child protection measures?
Yeah, sure, sir.
So what is the policy?
Here, the acceptance and all is very less. So we don't have particular policies here, sir.
No, but the child
maybe
is
Dr. Lokesh. Yeah.
The police have to be involved, if not social services, right?
Yeah.
The social service so you don't social service support is very poor. So you get a police personnel, they can come and interview, but you don't have a social service who can actually look after the child after that.
So the reason I ask is I know because we have been doing a study at Lucknow on this in India, the perspectives of abusive trauma. And again, what happens is typically the children are returned to the same family because apparently they are safer there than in
Absolutely.
foster care. It's very different how this is processed afterwards, even when you raise the possibility of abusive trauma. But
True.
be bad, right?
There have been IAP has drawn guidelines.
I think Dr. Lokesh, Rainbow has a policy, no? They make
There are
these
some phone
cases
numbers
as
to be
MNC,
contacted, but they're dying.
MNC or
So we
something,
don't
medical
have a good
legal
solution.
case.
Yeah. The police will be informed.
The police
but
will be
they will do
involved.
their investigations.
Yes.
But after that, they ultimately go back to the same environment.
Yeah, exactly. And most of these are extended families. So sometimes what happens is the abuser may be there in the same family, but there may be other people who are more protective of the child. That's what I've seen. So then you have to make it very clear to the other people, maybe the elders in the family, saying that this has happened, and they become defensive and they say, no, we will look after the child and all that. But you don't know how far it will go. I don't think social services has the resources to place these children in foster care or with other parents like it used to happen in the UK.
Absolutely. Yeah.
Yeah, and no one has written about this. I mean, there is no awareness about this. This child going back to the family, first of all, he's going to have so much neurological impairment now anyways for the rest of his life. So what is the care package going to be anyways?
Can I comment? I'm not meaning that we do it in the best way, but in Switzerland, in many pediatric hospitals and also in Europe, at least, there is a team caring for these children, because this is a very special, delicate matter, and just calling the police, they arrest maybe one of the parents, and this is no help for the family at all. So you need a specialized team who is aware of all the matters. The team is composed of pediatrician, of radiologist, of social worker, of lawyer, of maybe other kind of non-medical professionals, and they decide what is the best way to do before directly going to the police or to the court. And of course, the further management and the further kind of protection of that child is of utmost importance. This is more important than to put someone in jail. Do you understand what I mean? So if you have the resources, you should, if you have the resources in terms of men and women power, you need to get in touch with other people, with other centers, how they deal with that child trauma specialized team.
And one more question, is this from Rainbow itself, this case?
Yeah.
So at what stage was Nihaal involved? Because I'm sure he would have picked up the abusive head trauma and not call it venous sinus thrombosis.
No, this was done at, it wasn't done at Rainbow. The CT was done at Rainbow, which I don't report. MRI was done outside.
All right, but the CT itself tells you the story, right, in the beginning? Do you have
the CT also was done outside.
Yeah, it'll be useful to have your input if you're already in the chain, right? To start with, this shouldn't have been treated as venous sinus thrombosis.
No, I think if we get this actually was not treated as sinus thrombosis with us. In the referral hospital, the child was treated and they went home and they came back with at that point, we didn't consider sinus thrombosis.
Hi, good evening, everyone. Can I ask one question? The initial report was mentioned as a PT of 2 minutes, right? Was that before anticoagulants?
Yes,
So
ma'am.
this,
No,
so
this was
how is
after
it
that.
explained actually? Just by the consumption of the coagulation factors? I mean, because the first CT did not show that much bleed as well. So
First
are we dealing
PTI,
with
we
any?
do not know,
Yeah.
ma'am. So when they presented to us, it was more than 2 minutes. By that time, he was not on treatment. That anticoagulation and all was received prior to that.
But he had received, right?
Yes, ma'am.
But what exactly he had received, and can it affect the PT and APTT to such an extent? Because are we not like, have we ruled out completely any hereditary coagulopathies? If at all, it cannot be explained by any other means.
We have done a basic coagulation profile only.
Okay, I mean, that possibility also needs to be considered, at least if that PT and APTT is not explained by anything else. 2 minutes is too prolonged. No?
Yeah, but the child, yeah, Dr. Gupta, I agree with you, but the child also had an external injury. It should.
Yeah, but if they said that he just slipped and had a trivial injury, then with an underlying coagulopathy, it may just turn out to be a much larger hemorrhage than what you would expect with the trivial.
It also happened 1 month prior. Child had similar clinical symptoms of encephalopathy, dull activity. If a single point thing, then maybe.
Yeah, I'm just thinking about the other possibilities.
Yeah.
Okay, sure. Thanks.
All right. Thanks. Yeah, Kirti, if you're there, thanks, please.
Yes, I'm there. So this was a 20 months girl who was actually born of a twin delivery. She had a twin sister and of second degree consanguinity, was preterm of 1.5 kg birth weight, had an ICU stay of 7 days, but there were no major devastating events during the ICU stay. It was mainly for the weight gain purpose, and there were no neonatal seizures at that time. And prior to her presentation to me, she had mild motor delay. She had started walking at around 18 months of age. Mild language delay was also there. And at the time of presentation, with this background history, she had complaints of left-sided acute onset, left-sided weakness, which the parents noticed around 1 week back. However, they did not care that much. They thought that maybe she's doing it intentionally, so they didn't take her to the hospital on the first day. But when on day 3, she had a left focal seizure, then they took her to the hospital, and then she had repeated seizure on day 3 and day 5 after the onset of weakness. And she was evaluated at that time. On examination, she was conscious, alert. She was obeying commands. She was alert, little bit irritable, but had subtle facial dysmorphism, depressed nasal bridge, and her growth parameters, her height, weight, head circumference, all were less than 3rd centile. So there was a significant failure to thrive. With depressed nasal bridge, epicanthal folds, and low set ears. And her tone also, there was slightly on the hypotonic side. Maybe we can see the image.
Yeah. So here are the images, diffusion and ADC, and we have multifocal areas of restricted diffusion along the right frontal cortex over there, the centrum semioval on the left, bilateral actually, but more predominant on the left. Some areas of high signal changes on the basal ganglia on both sides, possibly the right thalamus. No signal changes on the cerebellum or the brainstem. The diffusion changes for reversal on the ADC sequences, possibly focal area on the right lobus pallidus, and yeah, again, nothing in the brainstem or the cerebellum. There is some degree of volume loss, the right more than left. On the flare and the T280 sequence, you can appreciate the cerebral atrophy. The right frontal lobe is slightly more atrophic than the contralateral side. There are also some periventricular hyperintensities which did not correspond to the diffusion weighted sequences, so possibly chronic changes in the periventricular and deep white matter over there, and also hyperintensities in the bilateral basal ganglia. The brainstem and cerebellum did not demonstrate any signal changes or volume loss. The MRA, you can appreciate that there is narrowing of the terminal internal cataract arteries and also the proximal middle cerebral arteries. Collaterals could not appreciate in the lenticular region, but possibly in the pile region over there. So thought of possibility, yeah, based on the imaging, the thought of possibility of differential time frames of ischemia, and given the MRA findings, the possibility of Moya-Moya syndrome or association to be considered. This was the question from Kirti. Kirti, if you want to, yes.
Yeah. So actually, if we can go back to the previous image. So when I first saw this MRI, I didn't have the MRI angio images with me. So what I thought of was some white matter changes in the flare sequence with patchy patchy diffusion restriction. So first thought that came to me was something like a demyelination, and maybe the atrophy was related to some insult in the past because she was preterm, or there might have been some old insult. So how do we, without angiogram, are there any imaging clues to suggest that these could be vascular? And how do we differentiate? Are there any radiological clues for that?
Dr. Mankar, you want to take it up? Or?
And I go for it. I was a bit distracted here.
Yeah, so the question is, Kirti, is how to differentiate between ischemia and demyelination? Is that the question here?
Yes, because here we don't see any vascular area of infarction. If it wasn't in any vascular territory, it would have been very easy to say that these are vascular.
Yeah,
but
so usually the small,
So usually the punctate ones, how do we say that it's more likely to be vascular without the MR angio in hand?
The MR angio wouldn't pick up these the punctate infarcts anyway. The small vessel ischemia can be multifocal. They usually don't predominate to a certain territory. If it's more large subparticle particle wedge shaped, then we can point it out towards a particular territory or a zone. But these small these small areas of restricted diffusion, they are usually more in ischemia than in demyelination. The demyelination usually only in the very acute phase we have restricted diffusion. Otherwise, they show facilitated diffusion. But the small vessel ischemic changes, as seen in this case, have a multifocal. They can present it multifocally on both sides without any territory. Only the large segmental ones, the middle cerebral or the middle arterial ones, can present with the focal wedge shaped or the typical pattern that you see in ischemia or infarcts.
Okay. So for this, so after Moya-Moya was suspected, and because there is also history of consanguinity, developmental delay, and some facial dysmorphism, so possibility of a Moya-Moya syndromic association was also considered. And neurosurgical opinion was taken, who advised, because it's a bilateral involvement and there are no collaterals yet formed, so it is in the early stages. So he advised that early revascularization procedure for this child would be good to prevent further strokes. My question here was like, is there any difference in the management for a Moya-Moya disease versus Moya-Moya syndrome, considering that there could be underlying different pathophysiology for both the things? Or should we straight away advise revascularization irrespective of this syndromic association? Any experience with that?
I just have a question for Dr. Nihaal. Why is it not focal cerebral arteriopathy secondary to iron deficiency anemia? Why are you saying Moya-Moya?
The narrowing on both sides, I don't think it is typically seen in iron deficiency in terms of the internal cataract arteries, and the strokes are of different timeline also. So,
very typical pattern of ischemic involvement in the brain in Moya-Moya, right? We get superficial deep arcs of different ages, and you've got an occlusive arteriopathy on both sides, so not FCA.
So FCN would be only on one side, and you wouldn't have so much of involvement. Is it right?
It's typically one side. I think lateral FCAs may have been described, but and then you have the usual FCA-I, FCA-D kind of subcategories. But the distribution of infarcts here, and I think the question was about whether this could be demyelinating infarcts. I don't think they are. Basically, this is just deep watershed territory and superficial cortical involvement in the watershed primarily. So all these patterns are typical for Moya-Moya. The pattern of infarction itself is not typical for FCA. You get more of a proximal infarct of the basal ganglia and maybe some white matter changes.
Thank you very much.
I have a minor comment regarding semantics. Can you go back or forward one slide? Moya moya is a Japanese term. It's written in one word. It means puff of smoke. And this comes because of the initial conventional angiography, where you had some kind of blush made by the contrast media in the collaterals. So that was the origin of the name. So it was not Mr. Moya and Mrs. Moya. It's just one word, not necessarily in capital letter. It's a Japanese expression. And to my knowledge, of course, Great Ormond Street has a large experience. The management, whether it's true Moya Moya disease or Moya Moya syndrome, is the same.
Okay.
I agree with Professor Volta, sir. Management would remain the same.
Okay. Okay. Thank you very much.
Yeah. Kasai, over to you.
Yes, sir. He's a 11-year-old male child with normal perinatal and developmental history, negative family history. So this child presented at 5 years of age. He was diagnosed as a case of pre-B cell ALL, received chemotherapy. And in 2019, subsequently, he had a CNS relapse. And further for that, he received chemotherapy and radiotherapy. And in 2019 itself, he came with fever, cough, cold, and diagnosed as CNS tuberculosis and received AKT for around 14 months. After which the child was doing well and in remission phase. In September 2021, he presented with progressive left eye loss of vision. And that time he was diagnosed as a case of optic neuritis. Sir, we'll go to the images first. Of September.
Right. Yeah.
Yes, sir.
I think I have April 22.
Sir, Nihaal, did you get that from the crown?
Sir, I had to send you the video.
Who's sir?
Achha. Okay, so just said here, but I think I didn't upload the video. I think I have the April scans. Is that okay, or
okay?
Anything on the September one?
So there was the left-sided contrast enhancement of optic nerve was there, sir. So it was attributed to.
Okay, so that was okay.
Yes, sir.
Maybe this one. Okay.
Yes, sir. So that was attributed to rest of there was a brain MRI which we had done, which was completely normal in the September 21 scan. And furthermore, the child, it was attributed to ethambutol toxicity, and the further management was being continued for this child. Later in April 22, he presented with excessive drowsiness, lethargy. Yes, sir. The excessive drowsiness and lethargy, and he was receiving chemotherapy during that last dose of vincristine, and he was on dasatinib too. So when he came with excessive sleepiness and drowsiness, the child was managed as a case of acute encephalopathy. During that time, his ABG was done, which was normal. CSF was normal when no metastatic cells were seen in this child. So MRI brain was repeated, was done in this child.
Okay.
Yeah.
So yeah, the flares you can appreciate multifocal areas of gray and white matter involvement, predominantly in the cortical and subcortical regions, also involving partially the basal ganglia, the parietal thalami, brainstem, and possibly the cerebellar white matter over there. Yeah, but predominant involvement of the peripheral regions of the brain, also some areas of the deep brain nuclei and the brainstem. On diffusion, there was no restricted diffusion. Yeah. After that.
Yes, sir. After that, the possibility of immune-mediated encephalopathy was being kept, and again, gene expert was sent for tuberculosis, which was negative. He received methylprednisolone at pulse dose for 3 days, and after which his consciousness is improved, his lethargy went off. So we thought this is in some immune-mediated process, and he was discharged on Vicelon gradually at 2 mg per kg per day. And subsequently, the next scan, he came for regular follow-up in August, and that time the subsequent scan was done in August 22. Yes, sir. So we
Okay.
wanted to compare the first scan, the April scan, August scan, and the
Got it.
October scan. Yes, sir.
Got it. So in comparison to the April scan, the subcortical cortical regions in the frontoparietal and temporal regions have reduced. The anterior cingulate cortex, the region is still persisting. The deep brain nuclear changes have progressed in comparison to the prior study. Brainstem has slightly come down in terms of the edema, but there are still residual abnormalities in the brainstem. Medulla is now more severely affected in comparison to the prior study. So this was from the September scan, and this is the October scan. October again,
Yes, sir. Then in October, he presented to us with clusters of seizures. Since 5 days every daily, he got 5 to 6 episodes of GTCS seizures lasting for 5 minutes. And that time we worked him up again. We thought it could be a ALL relapse or something. Then CSF studies were done, which was normal, no metastatic cells. And GCS, although was 15/15, but he was preferring to sleep. His bedside EEG showed no epileptiform activity, no status epilepticus, non-convulsive status epilepticus. His electrolytes were normal, and it's a part of workup. We had done his repeated his MRI again in October.
Yeah. So again,
So I just want to add here that when he was treated for optic neuritis, and that first scan which showed those white matter changes and as well as gray matter, we were not really sure what we were dealing with. And considering that he had one episode of optic neuritis, this was also considered to be some immune-mediated demyelinating process. And so he was treated with the IV methylprednisolone and then followed by steroids. And as soon as the steroids were like tapered, he again had a relapse with increasing sleepiness, and he has put on a lot of weight, looked like a Rad kind of a syndrome. And so then when we repeated his MRI now, you can just continue now.
Yeah, thanks. So the MRI again, the deep brain nuclear changes have progressed. Again, we have this confirmed white matter abnormalities again progressed in comparison to the study in the August in the frontal and pedicellarian regions. The brainstem findings are again evident. Some degree of middle cerebellar peduncles are also involved. Atrophic changes in comparison to the April scan, probably secondary to the steroid use. Contrast study for optic nerves did not demonstrate any enhancement. So based on the imaging findings alone, thinking of a possible autoimmune related process or immune mediated related process, these were the differentials which were thought of. I think LG1 was thought of by Dr. Kavita and team as a possibility because of the involvement of the particle and the basal ganglia. The other possibility only on imaging we thought of was HLH. Again, there was no pancytopenia. No, I think the ferritin levels were not done, but clinically the child was not looking in terms of an HLH. PML was another possibility which was to be considered, but the PML is primarily a white matter, predominantly a white matter disorder, and it is most commonly seen in adult age group than in the children. SSP, just given the multifocal gray and white matter involvement, but again, I don't think the child had clinical findings which are corroborative of an SSP. And demyelination, MOG can present with any form, so just to put it in the differential over there. At this point, I'll open the case for discussion.
We have done the MOG antibody, which is negative, and because NMO and MOG are done together, even that is negative. So we are really not able to pinpoint which antibody, but after the second dose of, we had to again pulse him now. He was on a low dose of oral steroids, which were being tapered. And on relapse, now we have again pulsed him. And we'll know in maybe a couple of weeks whether he's improving again. Till discharge, at least he had not improved much. Though last time he had responded dramatically. So we don't really know whether it is really some person raised the possibility of even methotrexate induced toxicity. But I just want to clarify that till April it was going on, and his MRI is in fact worsened after stopping the methotrexate. So we want the inputs.
The changes also don't look typical of methotrexate. They usually involve the white matter with restricted diffusion.
Okay. So
Nihaal, what was the diffusion on this?
No diffusion. I mean, facilitated diffusion.
even in October 2022 with all those subcortical changes.
Yeah.
It's unusual for MOG as well, right? All this, even though you have optic neuritis in the beginning of time.
But MOG turned out to be negative. So
You excluded viral encephalitis as best as possible because the whole brain is involved, including the cerebellum earlier on.
Not really, but only the CSF has been done, which is normal. But we have not done all the PCRs and all because
Might
this
be
did
useful
not.
because might be useful. I don't think it's falling into the categories of the usual suspects. So and why were they getting methotrexate? What's the background?
Because of the ALL, he was on maintenance therapy, and he had a CNS relapse in 2019. So till April 22, and he also received radiation. So that was another query whether radiation can induce some progressive leukoencephalopathy, though it is not just white matter. Such changes.
What does the contrast of the cerebral and cerebellar hemispheres show? Do you have that picture?
No, I don't have it, but no enhancement.
No enhancement. So this is not one of the necrotizing forms of methotrexate, which you sometimes can see.
No.
I would be very concerned about an immune suppression driven infection here, a virus most likely.
So you suggest to do a viral PCR and the CSF?
Yes.
The only thing which went against that is that as soon as we started tapering the steroids, there has been a clinical as well as a radiological deterioration. So that's the reason we were very strongly thinking of an immune-mediated autoimmune kind of process rather than a viral etiology. And there has been no fever at all, which may be, of course, because of Isolani is not mounting any fever. But
can the degree of brain atrophy be explained by the steroids alone?
I think so, because he's been on steroids for quite long now. September 21, because he had that optic neuritis. So since then, he was on that. And his drowsiness was also there at that time, which improved. So I really don't know what other differentials. Dr. Eugen, do you have any comment? Lokesh or anybody else? Any other thoughts? Hello.
I think the case is pretty complex. Yeah, anyone in the chat if they want to comment upon?
And you have looked at NMDAR as well, right?
NMDAR is pending. We had sent it. It is still pending. Yeah,
that's one thing. And the other thing in the context of ALL would be to look at HLH side of things, which would mean how do you test it? You could do a genetic screen or just test for natural killer activities and things, right?
No, for that now we will need the biopsy only of the lesion, because peripheral there is no evidence of HLH, because the hemat-oncologist is already involved in the care, and we had suggested this DD.
But my question is, how will a biopsy help with HLH? It's generally very non-specific on biopsy.
No, if it is like only CNS HLH, there's no way to prove it without doing the CNS biopsy. I mean,
is it? Wouldn't you be able to tell from the genetics?
I don't know, because this is a altered immune system, post-chemotherapy, post-treatment for leukemia, whether we need to look for any genetic predisposition. We didn't think about it.
I'm not a pathologist, but I thought the pathologists struggle to call something HLH in the brain.
Okay. Because we did think of it,
but test fibrinogen and things like that, right? To start with.
Sorry.
So you do ferritin levels and LDH levels.
No, they were all normal. They are all normal. Peripheral HLH is ruled out completely. Only thing, sometimes you may have isolated CNS HLH, but that what I understand is through biopsy only we can diagnose. Sure, we will look at the genetic angle. We did not think about it.
All right. Okay.
Yeah.
Thank you.
Thanks.
file?
Yes, sir. So this is a 14-year-old female. She was diagnosed as a case of precocious puberty at 6 years due to she had thalaki. And subsequently, her MRI scans were done, and the first scan revealed that there was a left cerebropontine angle epidermoid cyst. So subsequently, till then, 3 scans were done for epidermoid, seeing the progression of epidermoid cyst. The latest one was being on in 2022. So we'll discuss that, sir, scan first, and then we'll get to the other history.
So I have the scan on 2020. You
Yes,
can
sir.
appreciate the cystic lesion in the left cerebropontine angle, which demonstrates restricted diffusion, which is characteristic for epidermoid cyst. There is some degree of cerebral atrophy in the superficial frontal and parietal regions, but otherwise the brain was normal. Pituitary gland and the cellular-related structures demonstrate normal appearance. So yeah, the primary abnormality is the epidermoid cyst in the left CP angle.
Yes, sir. Then in May of 22, she presented to us with complaints of right-sided lower limb weakness, which lasted for around 2 to 4 days and subsided on its own. And as a part of workup, MRI was done in this child.
Sorry.
In May 22. Yes.
Okay, so that's the May 22 scan. On top is the diffusion weighted sequences. We have this focal area restricted diffusion in the left posterior capsule. I think the perimeral tracts on both sides up to the brainstem, these are actually related to the diffusion characteristic rather than pathological abnormality. The focal abnormality demonstrates corresponding signal changes on the flare over there. No contrast enhancement, no angiography related changes. The superficial or the deep white matter demonstrated slight hyperintensities over there, but there was no reversal on the ADC sequences. So primary focal abnormality in the left flick with no contrast enhancement and no angiography related changes. Yes, sir.
Yes, sir. So this
So
was...
just a second. So this lesion looks like demyelination or
can be ischemia and can be demyelination. At least two.
you're not sure. Okay.
Yeah.
Fine. Go ahead, sir.
Yes, ma'am. That time the child was a possibility of ischemic stroke was being kept, and the child was started on aspirin, and after which and amitriptyline, and the child was being further discharged. There was no complaint. The child immediately regained all the power. No neurodeficit in this child. Subsequently in October, now the child, she presented again with this time with left-sided upper limb and lower limb weakness, predominantly upper limb with a power of 3/5 and lower limb power of 4/5. And also this another history is significant, that there is a history of stroke in father. He had a left-sided MCA territory stroke, and his ANA levels had done in 2019, which were moderately positive. Rest of the stroke workup for the father revealed no abnormalities. Then considering that also, we did an MRI in this child, MRI with MRA and MRV, and MRI brain with spine screening and with contrast.
Okay, so I have the MRI of the brain, and you can appreciate focal heterogeneous T2 hyperintensity over there, with central hyperintensity is more prominent than the peripheral regions in the right centrum semiora or the superficial peritoneal region, which demonstrate areas of restricted diffusion. There's another lesion in the right posterior periventricular white matter going up to the cilium of the corpus callosum, the lateral aspects of the corpus callosum. But yeah, these are the two lesions, one in the right peritonic region or the posterior frontal regions, and one in the right posterior periventricular region. I have a T1, there's slight reduction of the corpus callosum, but other than that, no abnormalities. MRA and MRB doesn't demonstrate any significant abnormality. Spine, you sent me the spine images, but they were all T1 weighted or fat set weighted scans. We didn't have a T2 sagittal.
So that's what was done, sir.
Okay.
Yes, sir.
So what was on the
Feasibility study was
spine?
done. Yes.
Okay, you didn't do a T2 sedative then.
Yeah, probably that was the
Okay.
yeah.
Anything on the report for the spine?
So they have reported it as there is a lesion over D7 region,
Only
D9,
only
D7 region hyperintensity.
short segment.
We had the
So-
images, no? Sahil, you should have sent them.
No, he
No,
sent it, but
I've sent
they were
them.
all T1
Huh.
and they were
Then
not diagnostic. A
So
T2 would
there
have been
was a
helpful.
doubtful lesion actually. So we
Okay.
were not sure whether it is really an abnormality. There was a
Okay.
doubtful lesion. So we can take it as no lesion probably because she never had any
Awesome.
symptoms also related to it.
Got it. So after scan, Sahil, I think we did some workup.
Yes, sir. After which her NMO MOG antibody was sent, which was negative. ANA, which was done in this child, which was also negative. CSF IgG levels were raised in this child, and oligoclonal bands. The report came. It was negative for serum as well as CSF, sir. Rest of the stroke workup protocol, 2D echo and homocysteine levels, which were done in this child, which was also normal.
Okay. Right. So dealing with possibility of
my query is
demyelination
this,
muscle vasculitis.
yeah, the second lesion, what is it more likely to be radiologically?
It looks more like a demyelinating lesion because you have this heterogeneous appearance with central areas of hyperintensity. At least to me, it looks like a demyelinating foci.
With so much
And
of
also in the
restriction, diffusion
yeah,
restriction.
yeah, the acute findings they demonstrate tissue diffusion. That's possibly
it's got a typical broken ring of diffusion restriction, right?
Yeah. Yeah.
And there's the other lesion as well, so it's multifocal.
Yeah.
Okay.
Okay, so I think that what would the workup be, Dr. Veda? Anything looking for my
Yeah, so we have got high CSF IgG levels, so OCT is negative, and so we will be treating on the lines of recurrent demyelination, either MS or though it's not really meeting all the criteria for MS, the lesion, especially this one, is a very large one and looking more like most what you see in MOG and all, though MOG is negative. So seronegative ADAM like picture only will be considering for now and treating with a little longer immunosuppression. But comments are invited from others.
Yeah.
What should be the best line of management for this child?
Kavita, would you call this a clinically isolated syndrome?
No, this is the second episode. No?
Second event.
First
Within how
time
much
also
time
she had. This is
more than 3 months, I think.
yeah, and that
6
time also
months,
she had a neurodeficit, only right limb weakness, which recovered in 4 days.
Okay.
And this
So
time now this is a little longer and her power is still not recovered. The upper limb, left upper limb.
Okay.
Any comments, Dr. Oigel?
Any comments on the treatment?
Yeah. Yeah, aquaporin 4 was sent and NMO antibodies were negative.
You have a dissemination in time and space, and the question is just wait and see and follow, or would you escalate your treatment like with fingolimod or something like this? I'm not an expert. I would rather wait and see and have another MRI, say in 3-4 months. But if there is an increasing load, then you would consider escalating the treatment towards multiple sclerosis.
Yeah, we were also thinking on the same line because the lesions like this time are not really looking very typical of MS, like very huge lesion and looking more like MOG antibody associated, those large lesions with a lot of diffusion restriction.
But what Dr. Nihaal said, this open ring sign, of course, is not specific, but can be kind of an aura of an MS. At least I've seen that on a follow-up MR.
Yeah, I agree. And the reason I asked for the difference in time was you have satisfied the McDonald's criteria here, haven't you?
Definitely. Yeah. There is dissemination in time as well as space. And even in
So-
this MRI also, there are two lesions already. And
So-
I don't know whether this splenium one is a little older one.
So would
So
we
that is
not
not showing
then,
anything.
should we not be having a discussion about, whether it's going to be an ocrelizumab or some kind of a higher agent than
Yeah,
just
that's what we are planning because once we got the report that IgG is high, that is also another indication that there is a immune process going on in the CNS itself and
and
more
have you
towards
checked
MS.
Epstein-Barr virus?
Sorry?
Have you checked EBV?
No, no. Why do you think so?
This is strongly associated, right? And where it starts and where it goes, it all started in a very weird way with the epidermal and all that. But Epstein-Barr virus is a strong association because, in a way, we have to still exclude all other possibilities for satisfying McDonald's, right?
Mm-hmm. Okay, EBV we did not think about. Let me read about it then. Mostly we were
Still be
going on the
causing
lines of either.
The driver might be an EBV. That's my only question.
Okay, okay. Sure, sure. Any other comments?
So you'll probably start off with treating with steroids and seeing how she improves. But if you're going down the line of MS, what would you start, Dr. Kavita?
No, as of now, we had started rituximab only because I was thinking more of a seronegative Adam kind of picture.
Okay, okay.
Till we got the immunoglobulins and all.
Mm-hmm. Okay.
Okay, thank you.
Yeah.
Right.
Nihaal, before you move on, there are at least 4 or 5 lesions, right? How many do you count?
One,
I can see a splenial.
2,
Yeah.
3, 4. That's 4. And the one which was
Yeah,
that is not there. The previous one is not.
That's gone away. And
Yeah.
the morphology would most fit MS anyways, from our perspective.
Yeah, it would. Juxtaparticle and periventricular.
Exactly.
Kind of. So yes. That's our last case. We'll rejoin on 11th November, but I think Dr. Mankad has a few messages he wants to share with you guys. So, Dr. Mankad, can you share your screen?
Oh, not particularly. I mean, I can just
Okay.
we
Okay.
have
All right.
minutes for all the people present here. Nihaal and I have been thinking about consolidating good work that he has done so far. And by establishing within India a Paediatric Neurosciences academic foundation. But when we say it's within India, the outreach of that would be for all of Southeast Asia. So this meeting stays where it is and it's added value. But we were hoping how well do we kind of spread our wings a little bit more and make it effective for other countries around as well. And this discussion also happened between me and Kavita, particularly in ICNC Antalya. And we will be looking for support from organizations like that. But the idea is, as you can see, there's lots of fine, deep phenotyping of complex cases from a radiological perspective, at least, that happens in a platform like this. And then the vital clinical input from experts from all over. And you guys are very, very good with the science of not just radiology, but clinical sciences as well. But is this something that you think we have an appetite for, even if it's a periodic event? Leading on then to develop more collaborative research projects and actually consolidate the case types together, develop multidisciplinary teaching courses, and even mentor students, not just residents in neurology, but mentor students who are starting off from medicine basically up until where they want to become if they have an interest in neurosciences, whether it's pediatric neurology, neuroradiology, or even surgery going forwards. It's a very open-ended thought at this point in time, but unless and until we have something embedded, it'll be very difficult to set up data sharing and even formalizing these discussions and reports. I'm not sure you guys can go back to your respective hospitals and put Nihaal's name on your clinic letters, for instance. I don't know what the arrangement for that is, but the governance of this would need to be strengthened. So it's an open question, and I thought I'll pose it here before I go to other organizations and ask them what they think, but might be a good place to start. a lot to absorb in one meeting, but those who have sat through and the 62 still attending, if you want to reach out to Nihaal or myself, then please feel free. And you don't have to be particularly restricted to India. We have representation here from Libya, for instance. So very happy to create a wider network of like-minded people and meet every now and then. And got Kiran from Pakistan as well. Kiran, I was speaking to Tipu the other day in Antalya. He was quite keen from a neurology perspective to get something started across the board. And the one thing that we could unify ourselves with would be good education that we're already connected by in the last few years now. So I'm going to drop my email, and Nihaal, you can do the same as well on your chat. If you can just CC both of us, at least we can keep an eye on what comes through.
Yep.
Your email, I know, is well advertised everywhere else. So you got that. Nayana has a suggestion if she wants to speak up.
Let's see. No, could you type it in? I'm just asking the IT guys to make a panelist.
And Eugen, you're already connected to many other countries in the world. What are your thoughts on an endeavor like this?
I'm connected a little bit to Germany and by history with Armenia, the Armenian hospital. You know, as a kind of dinosaur living in the Pampa, it's not, of course, we have internet, but it's not that easy for me.
Actually, it's a very good idea, Dr. Kshitij. You can have a themed discussion, right? If you're having it across the board, something like, pediatric stroke, for example, or demyelination. And you can have 2-hour session just on that with a bit more academic focus. At the moment, we are just discussing our difficult patients and how to manage it all, but you can have a bit more themed approach, I would have thought. I think it's a very good idea. You've got it. Just have to see the times, because we'll be able to spare time only in the evening, most of us who do private practice. So we'll not be able to spare a whole day or half a day and all that. It'll probably be like 2 hours, 3 hours we can spend and do it. Yeah.
Yeah, Dr. Rashmi, actually the theme-based thing actually I forwarded to AOC and a few others. I think last year itself to do a 2-hour session every Sunday, every 3 months or 2 months, but I think being a response for that. But yeah,
Dr. Kavita Srivatsav is the head of AOC and academics. So
no, I'm the secretary. We have a separate education chapter which looks after this thing. We had forwarded this, and they feel we are already having too many activities as of now. But surely we can accommodate one neuroradiology session, definitely, and it's the need of the hour, definitely. So if we have any concrete proposal and you can just send it, I will forward to the education vertical. And I think they should be very happy to include one.
Sure. I think the bigger picture of this was to set up clearer data sharing agreements in place as well for prospective work, because every center might have one example of a case, but if you put 20 centers together, it becomes a good solid series. And I think we should be focusing on that kind of collaborative research going forwards rather than isolated case reports.
And thanks for adding me as well. This is Praveen, and I'm just talking from Nayana's profile since me and my co-fellow was joining this morning. And we are actually Pediatric Neurology Fellow in University of Arkansas, United States. So we do actually follow this lecture series. We actually like it because both of us actually did our med school and residency in India, and then we actually moved here. So the only suggestion is if you all can share the link, we can actually share with our colleagues here because this is our dedicated lecture time in the morning on Fridays. So this actually works easy for us. And
yeah, we can share the link. It's on social media, but yeah, I can share it with you if you want me to.
yeah, and I can share there are like almost like 8 to 9 like neurology, like Indian neurologists associations here, and we do have lecture series on Saturday evenings. So and like people are always interested in joining the lectures here as well, because like you said, even the pediatric neurology team is so small, and even here there are like only one fellow per year. So we are happy to join the conference. As long as you're okay, we can share the link with all the in-networks.
Yeah, please do. It's openly shared on social media anyway. So
Nihaal tweets out the link openly on Twitter. So if any one of you can at least keep an eye out there, it's sent regularly. And once you register, you get your emails on a couple
it's
of
a one-time registration. Yeah.
Okay, that sounds good.
And you can share your cases too. It's not limited only to India. So
yeah, that was my question. So how do we share the cases with you all? Like,
you can email them to me or WhatsApp me. Probably WhatsApp me or email me. We'll take it from there.
Yeah, that sounds good. Yes.
Right.
In fact, we have a competition. We have to really run fast and catch the train because Nihaal's Excel sheet gets filled so fast. I have to tell my fellows, first day itself, you have to fill it. So we'll have more competition now. Great.
I agree. We'll have to fill it in as soon as we finish the meeting, right? You will have to fill it in.
That is why I think we will keep the Indian meeting as it is and probably build on it in some way or the other. That was kind of because we don't want to disturb the syntax of how things are here. And it's useful. And it's kind of in real time now as well, where we started, things were a bit old and now it's in real time weekly cases. So Nihaal and I can think about how we can expand this, but maybe in a slightly different dimension or space.
Okay, I think that's it from us. All right.
Okay, thank you very much, everybody.
Thank you.
Thank you. Thank you, everyone. Good
Bye-bye.
night. Bye-bye.
Bye again.
Bye. Thank you so much for your
Thank you.
input and preparation.
Thank you. We'll miss you the next time. Hope you have a good time in Germany.
And no
Bye.
sir to be used next time. Otherwise, I will stop attending. Bad on people who are accepting the sirhood.
Got it. There you go. There's someone saying thank you, sir. All right. Bye-bye.